Hi guys, welcome back to the Physics for MedEd. Dr. Patil here. So I had done a couple of weeks back a clinical reasoning masterclass on the PW MedEd Next channel, and many of you had requested for me to do that for the remaining systems, and you had also requested that we should do this clinical reasoning masterclass for other subjects as well. And we're listening to you, and we have started this clinical reasoning masterclass series. This is continuation of what I had started in the MedEd Next. So in the MedEd Next, I have already discussed few systems. Today we will discuss one system, and then I will also continue through Instagram giving you the clinical reasoning tips and other essential information that you need to answer the MCQs. Okay. Now when I use the term clinical reasoning, what does that mean? It primarily means using the evidence-based practices for the diagnosis and management of diseases. But of course, here we are trying to help you ace your exams, mainly the MCQ based NEET PG exams or FMGE exam better. And what I need to do to be able to ace those exams, one of the major hurdle for most of the students is that, sir, I have studied everything about a disease, but then when I go and see the questions are clinically oriented. There is a long story of patient symptoms, examination findings, investigations, and then I may not be able to make a diagnosis from this whole story. So in that case, sir, how will I get to know whether the question is talking about, let us say, myasthenia gravis, or whether it is talking about GB syndrome, or whether it is talking about stroke? If I'm not able to understand what this question is talking about, then how will I be able to answer the question, right? So please remember, now whenever you see the clinically oriented questions, it has an anatomy of a clinically oriented question. What is the anatomy? Generally, the examiner will put some patient symptoms. If you dissect the question, you will notice that there are symptoms mentioned. Symptoms themselves may hold the clue for diagnosis. For example, if the question is talking about someone presenting with rapidly progressing ascending paralysis, it's already talking about, most likely talking about GB syndrome. Symptoms, then they may mention some investigations. Like for example, they mentioned that a person presented with ascending paralysis and we did nerve conduction study, which is a good investigation for diagnosis of GB syndrome, right? Or they may also be mentioning some signs. And then after this, you have to make a mental diagnosis of what this question is talking about. Examiner may not always be asking about the diagnosis. When you deal with clinically oriented questions, only 20% or out of 5 questions, only one question they ask you what is the diagnosis. Remaining all cases, you have to make a mental diagnosis. Okay, once I know, let us take the example of GB syndrome. Let us say from the whole clinical story based on the symptoms, investigation, signs, whatever they have mentioned, I've made a diagnosis of GB syndrome. Then the examiner will ask you, what is the most common cause for death? Or he may ask, what is the investigation of choice? Or he may ask, what is the most common preceding infection? So this is how clinically oriented questions are built. So examiners are primarily trying to test whether you can navigate through this information to reach this diagnosis. You will be able to answer rest part only when you reach the diagnosis. And you might have read everything well about GB syndrome. You know what is the most common cause for death. You know what is the investigation of choice. You know what is the most common preceding infection. But if you're not able to recognize that this whole story is about GB syndrome, then all that knowledge goes waste in your exam, right? You will not be able to get to the right answer. So in this clinical reasoning masterclass, this is what we are trying to do. We will give you tips and clues which help you to reach the diagnosis. I have already done the neuro and cardio. Neuro and cardio is covered on another video module which is called Clinical Reasoning Masterclass, and this is available on our one more sister channel which is called as MedEd Next. You search the YouTube for MedEd Next and you get that channel, and on that channel just search for the Clinical Reasoning Masterclass and you get that. Okay, so today I will address the respiratory system. Now for the gastroenterology, whatever Sandeep covers in surgery is more than enough to deal with the clinically oriented questions. And for hematology, whatever Dr. Ranjit covers in pathology, the approach that he teaches is more than enough for you to reach the diagnosis, because hematology is more about pathological diagnosis than clinical. So we'll now deal with another important system, that is respiratory medicine. Now in respiratory medicine, what are the major diseases from which the questions can be asked? Asthma, COPD, interstitial lung diseases, ARDS, pneumonia, bronchiectasis. Now when I read a clinically oriented question, how will I get to know that the question is talking about asthma? How will I get to know that it is COPD, it is ARDS? Today we will learn that, right? We'll take up one by one. So we'll start with asthma first. Now how will I recognize that a particular question is talking about asthma? So most important thing to deal with the respiratory medicine questions is to know whether these diseases are restrictive diseases or obstructive diseases, because most of the questions will be based on interpretation of PFT. So if I go back, then we know asthma is a obstructive disorder, COPD is also an obstructive disorder, while the ILD, ARDS and pneumonia, these are restrictive disorders, and bronchiectasis again is an obstructive disorder. So if I know to interpret the PFT, I already would have ruled out some of these options. Like, okay, if the PFT is suggestive of restrictive, it can't be asthma, it can't be COPD, it is unlikely to be bronchiectasis. But if the PFT is suggestive of obstructive, then it can only be asthma or COPD or bronchiectasis. It can't be ILD, ARDS or pneumonia, right? That is one. And if you go back to my previous video where I am talking primarily about symptoms in neuro, cardio and all, symptoms hold a lot of clue. Like young person with sudden cardiac death, you start thinking about hypertrophic cardiomyopathy, right? But when it comes to respiratory medicine, symptoms may not hold the major clue. Why? Because what is a symptom of asthma patients? Wheezing, okay. Shortness of breath, yes. Cough, yes. What about COPD? Wheezing, shortness of breath, cough. What about ILD? Okay, may not be wheezing, but they will have cough and shortness of breath. What about ARDS? Cough and shortness of breath. Pneumonia, cough and shortness of breath. Bronchiectasis, cough and shortness of breath. So because majority of the respiratory disorders present with similar symptoms, we are relying heavily on the investigations for the diagnosis. So before I even talk about asthma, let us understand the interpretation of the PFT. PFT interpretation to deal with clinically oriented questions on respiratory medicine. So in the PFT, I am mainly interested in two parameters. One of them is FEV1 and the second one is FVC, and I am looking at its ratio, FEV1 by FVC ratio. This FEV1 by FVC ratio, if it is less than 0.7, it is suggestive of obstruction. It is suggestive of obstruction. And if FEV1 by FVC ratio is more than 0.7 in a patient with respiratory disorder, it is suggestive of a restrictive disorder. It is suggestive of a restrictive disorder, or there may not be any respiratory disease, patient may be normalcy. So if I can see this ratio, I would have already ruled out half of my differential diagnosis. Right? Let me give you an example. Let us say I got a patient with, this is a story of a patient, he presented with cough and shortness of breath just like any other respiratory disorder patient, and the question talks about FEV1 by FVC ratio of 0.54. Now tell me, this is an obstructive disorder or the restrictive disorder? Obstructive disorder or restrictive disorder? I gave you the flow chart, right? When the ratio is less than 0.7, it is an obstructive disorder. When it is more than 0.7, it is a restrictive disorder, or there is no respiratory disorder at all. So looking at the ratio, what is it suggestive of? This is suggestive of an obstructive disorder. Obstructive disorder. So in the respiratory medicine, what all are considered as obstructive disorders? Asthma, COPD, bronchiectasis. So the moment I see this picture, I have already ruled out. What I have ruled out? I have ruled out all these restrictive disorders. That patient cannot be having ILD, he may not be having ARDS, he is not a case of pneumonia. Clear? So he can be asthma, he can be COPD, or he can be bronchiectasis. Those three are the differential diagnosis. Clear? Okay. So now we will look at the individual diseases. First, let us start with asthma. Asthma is an obstructive disorder, and being an obstructive disorder, what will be my FEV1 by FVC ratio? In this case, the FEV1 by FVC ratio will be less than 0.7. Okay. In terms of clinical features, if the question is talking about clinical features, what symptoms we are expecting? We are expecting wheezing, cough and shortness of breath. Cough and shortness of breath. Now, in this case, if I have to differentiate this asthma from the other obstructive disorder, that is COPD and bronchiectasis, how can I differentiate? So please remember, asthma is an obstructive disorder with reversible obstruction. Now what do I mean by that? The obstruction that we have here, if I give a bronchodilator, it can be reversed. It is not a persistent obstruction. In COPD, it is persistent obstruction, right? So when it comes to investigation for a case of asthma, the investigation of choice for the asthma will of course be PFT, which will be showing obstructive picture. And the question is, how do I differentiate between COPD and asthma? All I need to do is, I need to prove that this patient's obstruction is reversible. How do I prove it? By giving a bronchodilator. So for that, we do a test called as bronchodilator reversibility test. Bronchodilator reversibility test. Now, how will I interpret this bronchodilator reversibility test? Whenever we diagnose a patient of a respiratory disorder with the help of PFT, we already have measured FEV1 by and FVC for measurement of this ratio. So now I already know what is this baseline FEV1. So what I will do is, I will check the patient's baseline FEV1, which is already done for the diagnosis. And then after that, we will administer a short-acting beta agonist. Short-acting beta agonist, like for example, salbutamol. And we will repeat the FEV1. This FEV1, we will call it as post-bronchodilator FEV1. Why am I calling it as a post-bronchodilator? Because we have administered a bronchodilator. We have administered a SABA. And we will see how much is it, and compared to the previous value, how much it is increased. So if I see an increase of more than 12%, more than or equal to 12%, or if I see an improvement of less than 12%, more than or equal to 12% increase, or less than 12% increase. Less than 12% means it can be 0 as well, no increase at all, or less than 12% increase. So if the FEV1 increases from previous value by more than 12% or equal to 12%, that means the bronchoconstriction is reasonably reversible. So I can now call it as reversible obstruction. This is suggestive of reversible obstruction. Reversible obstruction. So among the three major obstructive disorders that we discussed, that is asthma, COPD and bronchiectasis, only asthma is reversible obstruction. So for all practical purpose, it is equivalent to asthma. On the other hand, if there is less than 12% increase, it means it is persistent obstruction. It means it is persistent obstruction. So what are the other conditions where I can have persistent obstruction? COPD, of course, and bronchiectasis. So that means either we are dealing with COPD or bronchiectasis. These are the three major obstructive lung disorders. So now I know how to differentiate between these obstructive lung disorders, right? So let us see if we can interpret it now. Here I have got the post bronchodilator BDR FEV1 increased by 8%. 8%. So now what could be the diagnosis here? Can it be asthma? No. For asthma, how much I need? Whatever is the baseline FEV1, it should increase by more than or equal to 12%. So that is not the case. So then what it could be? Either it could be COPD or it could be bronchiectasis, right? So as we go forward, we will also learn how to identify whether the examiner is talking about COPD or he is talking about the bronchiectasis. Okay, very good. So this is the approach that we are going to follow. So by following this approach, asthma, we have learned that it is reversible obstruction. So we do the BDR test and we will see more than or equal to 12% increase in FEV1 if asthma is present. Okay, so now you know how to recognize the asthma in a clinically oriented question. What? Patient present with some respiratory complaint, don't give too much importance to it because they are relatively standard symptoms of respiratory disorders. Primarily pay attention to the FEV1 by FVC ratio and bronchodilator reversibility test. That will help you to reach the diagnosis of asthma. And when I am talking about asthma, there can be another level of questions related to asthma. Okay, from the story I got to know that examiner is talking about asthma, and then he tells you that this patient was on a combination of inhaled corticosteroid plus LABA for treatment. He is not responding, and now the examiner wants to use some modern medicine, like for example dupilumab is one option the examiner is giving you. Another option he gives is oral steroids, and then he will ask you which one would you prefer when the patient of asthma is not responding to inhaled corticosteroids and LABA. Like from this flowchart, you have come to the diagnosis that question is talking about, let us say asthma, and then the examiner is asking which one would you prefer when he is not responding to the standard treatment. Okay, so again, to answer these kind of questions, we also need to know, once we have diagnosed it as asthma, the story is not over. We also need to know whether it is, there are two types of asthma, type 2 and non-type 2 asthma. Type 2 and non-type 2 asthma. So the extra point you need to know about the asthma is asthma subtypes. Asthma subtypes. So we'll classify asthma as two major types. One of them is called as type 2 asthma and the other one is called as non-type 2 asthma. This classification is primarily based on which type of T helper cell is involved in the inflammatory process. So if it is Th2 mediated, if it is T helper cell 2 mediated, then it is called as type 2 asthma. And if it is mediated by other helper cells, means Th1 and 17 mediated, then it is called as non-type 2 asthma. So this type 2 asthma, how will I recognize that this patient of asthma is having type 2? Because for type 2 asthma, we can use these all monoclonal antibodies that are available, not for the non-type 2. So how will I differentiate? Mainly the examiner will mention markers of type 2 asthma. Markers of type 2 asthma. So what are the markers of type 2 asthma that you need to know? The first one is eosinophils. So there will be increased eosinophil count. Eosinophil count. Primarily when Th2 gets activated, there is recruitment of eosinophils for causing the inflammation. But for non-type 2, it is neutrophilic inflammation. So if I see that there is a patient with asthma and he has high eosinophil count, it means it is type 2 asthma. Okay. The second marker is, there is something called as fractional exhalation of nitric oxide. We measure how much nitric oxide the patient is exhaling in his breath. Higher it is most likely asthma. Okay. Then third, increased serum IgE levels. Serum IgE levels. Higher the serum IgE level, it is more likely that we are dealing with type 2 asthma. And there is also a new marker related to bones but also seen to be elevated in patients with type 2 asthma, that is osteoprotegerin. So any question which talks about high eosinophil count or FeNO being elevated or serum IgE levels being elevated or osteoprotegerin being elevated is talking about type 2 asthma. These all will be normal in non-type 2 asthma. There are no dedicated markers for the non-type 2. We don't do any specific investigation. All we do is we do the markers for type 2. If they are positive, that means they are elevated, it is type 2. If they are not elevated, it is non-type 2. Non-type 2. So now let us go back to this question. Okay, I will just rephrase it. Let us say I got 20% increase in the FEV1. So that means we are dealing with what? In that case, the diagnosis becomes asthma. And once I know the diagnosis is asthma, I will also look at the markers, right? Markers of type 2 positive, type 2 present, then it is type 2. If those markers are absent, then it is non-type 2. If they are absent, then it is non-type 2. So I hope the approach is clear. Any patient with respiratory symptoms, first look at FEV1 by FVC ratio. If it is 0.7 plus, non-obstructive means restrictive disorder. Less than 0.7, it is obstructive disorder. After that, mainly to differentiate between asthma and COPD, look at the bronchodilator reversibility. 12% or higher improvement in FEV1, it is the asthma, reversible obstruction. Less than 12%, it is COPD or maybe bronchiectasis. Then if it is asthma, to know whether it is type 1 or type 2, mainly see the markers of type 2 that we just learned. If the markers of type 2 are present, then it is type 2. If they are negative, then it is non-type 2. Now why am I asking about it? Because when we are dealing with type 2 patients, so biologicals or monoclonal antibodies used in asthma, not all can be used for all patients. So if I am dealing with type 2 asthma, I can use everything. For type 2 asthma, I can use all the available monoclonal antibodies. But for non-type 2, there is only one monoclonal antibody that is approved. So what all I can use for the type 2? There is a monoclonal antibody against interleukin 4 receptor. It is called as dupilumab. Dupilumab. It is the monoclonal antibody against interleukin 4 receptor. Then I have omalizumab, which is monoclonal antibody against IgE. It is anti-IgE. Okay. Then I have mepolizumab and reslizumab. These are monoclonal antibodies against interleukin 5. And then we have one more, benralizumab, which is a monoclonal antibody against interleukin 5 itself, but not directly, but at its receptor, that is anti-IL-5 receptor. And we have a very new antibody called as tezepelumab, monoclonal antibody called tezepelumab, which is against anti-thymic stromal lymphopoietin or TSLP. All these are there. So from the story, if you come to the conclusion that this examiner is talking about type 2 asthma, you are free to use any of these. But if you come to the conclusion that this is not type 2 asthma, then as of now there is only one monoclonal antibody which has been approved for use in non-type 2 asthma when they do not respond to inhalers, and that is tezepelumab, which is, as I've just discussed, it is the anti-thymic stromal lymphopoietin. Basically, tezepelumab regulates the activity of the Th2 as well as Th1 and other helper cells. But in case of these dupilumab and all, they are primarily useful only when there is a Th2 mediated inflammation. So if they ask you again, which monoclonal antibody can be used regardless of subtype of asthma, then it is again tezepelumab. Can be used for type 1 as well as, type 2 as well as non-type 2. Okay, I hope this is clear. So this is how you reach the diagnosis, and you will be able to answer the questions related to asthma from the clinically oriented question, right? So that summarizes our brief what you need to know about asthma. Now next we'll go to the COPD. So if the examiner is asking me to recognize a question on COPD, how will I recognize? So if the examiner is talking about COPD, there will be few features of course mentioned. What are those? If the question is about COPD, COPD is also an obstructive disorder. It's an obstructive disorder, and being an obstructive disorder, the FEV1 by FVC ratio will be less than 0.7, but unlike asthma, this is a persistent obstruction. Persistent obstruction. So here bronchodilator reversibility test may not yield you a good improvement in FEV1. Okay. Clinical features wise, these patients will also often have wheezing, cough, and shortness of breath. Now in this clinical story, they may give you a little more details. In the sense, they may mention the history of smoking. Okay. Then they may also mention some important signs in the question. What are the signs they are likely to mention? The first and the common signs that COPD related questions talk about, mainly in patients with emphysema, is that they will have the so-called pursed lip breathing. Pursed lip breathing. Then they will have this barrel-shaped chest. Barrel-shaped chest. And then they may have this a very peculiar posture which is called as tripod position. Tripod position. Now what are all these? Now patients with emphysema, they have irreversibly dilated alveoli, and when I have an irreversibly dilated alveoli, let us say this is trachea, bronchi. Now from the bronchi I will have eventually what we call as respiratory bronchiole, then alveolar ducts, and then alveolar sacs. These are alveolar sacs, alveolar ducts, and respiratory bronchiole. Collectively, one respiratory bronchiole, all of its alveolar ducts and alveolar sacs put together, we call it as an acinus. Emphysema refers to irreversible dilatation of the acinus. So when it becomes irreversibly dilated, what happens to pressure inside this acinus? Earlier this was the size, now the size is large and it is irreversibly dilated. It is not going to get back to its original shape. Then only I will call it as emphysema. What happens to pressure inside it? You might have studied about this Boyle's law in your chemistry and physics as well, which says that in a container or a chamber, pressure is inversely related to volume. So if volume increased, pressure decreases. So pressure generally in these emphysematous parts of the lung is low. So when the pressure is low, it becomes easy for me to bring the air from atmosphere into this acini, because air will flow from high pressure to low pressure zone. But where will I have the difficulty? I will have the difficulty when I have to exhale, because for me to exhale, the pressure in the acini has to be more than the pressure in the atmosphere. Then only air will leave back to the atmosphere. So for that, I need to make this acini smaller, recoil. When it becomes smaller during expiration, pressure inside increases and air goes to the atmosphere. But because these are irreversibly dilated, their pressure is not going to increase because they are not going to recoil. So if their pressure does not increase, the air that has come to this acini cannot leave out to the atmosphere. So air gets trapped. As more air gets trapped, to accommodate that, the acini dilates more. So now the acinus is in a vicious cycle. So to make sure that the patient brings that air stuck in the acini which is dilated out easily, they make some adaptations. One of the adaptation is pursed lip breathing. So when they purse the lip, that means their mouth opening is made small. Pressure inside the airway starts building up, and that higher pressure also helps us to build pressure in the acini, and higher the pressure in the acini means more easier for us to exhale the air out. Okay, one. Second, barrel shaped chest, because the acini are becoming inflated, the lung starts expanding. So to accommodate that, the chest becomes barrel shaped. Okay. Third, tripod position. So these patients, whether you go to wards and see like your respiratory wards, whether the patient is sitting or standing, they are most comfortable when they are leaning forward their elbows or hands on the thighs. This position is what we call as tripod. So your mostly COPD patients with emphysema will be doing this with their bent forward, right, elbows or the hands resting on the thighs. This position we call it as tripod. How this helps? When they take this position, the diaphragm gets pushed up. Diaphragm pushed up means pressure inside the thorax increases. Pressure inside the thorax increases means it will be reflected to the acini. It makes it easier to exhale. So they are making those adaptations. So if the examiner is talking about these findings, that is pursed lip breathing or barrel shaped chest, or if he is giving the images of someone pursing their lip and breathing, or someone having this barrel shaped chest, or someone taking the tripod position, he is talking about emphysema. And in the context of smoking and all, we are talking about COPD. Okay. Another thing the examiner may mention is that these patients of COPD often may have cyanosis and cough with expectoration. And when examiner is talking about the cyanosis and cough with expectoration, he is pointing towards a component of COPD called as chronic bronchitis. Chronic bronchitis. Chronic bronchitis. And please remember, whenever examiner mentions you, he wants you to think of chronic bronchitis, he mentions the definition in the question itself. What is the definition of chronic bronchitis? Cough which is productive, means with sputum, for at least 3 months per year for 2 consecutive years, or sometimes they mention it as more than 2 months, which is nothing but 3 months. Cough with expectoration for more than or equal to 3 months per year for 2 consecutive or sequential years. That is the standard definition of chronic bronchitis. So these findings generally will not be mentioned in a question of asthma, because asthma is reversible obstruction, so you will not be seeing all these findings. In COPD, these are classical. Okay. Then when it comes to the investigations, of course, again, when it comes to investigations, investigation of choice for majority of the respiratory disorders will be PFT. In the PFT, as we already know, we are getting the obstructive picture, that is FEV1 by FVC ratio of less than 0.7, less than 0.7. And after this, when we go for the bronchodilator reversibility test, what am I getting? Bronchodilator reversibility test. It will show less than 12% increase in FEV1. Less than 12% increase in FEV1. So with that, we make the diagnosis of COPD in a question. Now you may be thinking, sir, what about bronchiectasis? I'll tell you how to differentiate bronchiectasis and COPD. Bronchiectasis patients also present with cough with expectoration. Cough with expectoration. What changes is the context. If they're talking predominantly about smoking and other findings, it is leaning towards COPD. But if they're talking about patient having the conditions known to cause bronchiectasis, like cystic fibrosis or post-infectious, means post-TB, Carter-Jenner syndrome, then it is pointing towards bronchiectasis. Second, in the bronchiectasis investigations, they will not only stick to the PFT, they will also talk to you about the radiological investigation. Okay, so now I hope you know from the question how to recognize asthma question and COPD question. We'll go to the bronchiectasis now. Bronchiectasis. So if the question is about bronchiectasis, as we already know, this is also an obstructive disorder. This is also an obstructive disorder, again with persistent obstruction. Persistent obstruction. So that means when I do PFT, my FEV1 by FVC will be less than 0.7, and BDR test, bronchodilator reversibility test, will show less than 12% increase in FEV1. So far it looks similar to COPD, right? But where the things change? The things change when it comes to history. So if the question is talking about in the history, like if it is a known case of let us say cystic fibrosis where bronchiectasis is known to occur, or Carter-Jenner syndrome, or any other ciliopathies, or tuberculosis. In India, tuberculosis is the most common cause for bronchiectasis. TB is the most common. So if I am the examiner and if I am setting a question on bronchiectasis and I want to give you clinical clues, I will primarily mention that here is a patient who was a known case of TB. He has completed ATT and now he is presented with persistent cough with expectoration. So now I am making you think about bronchiectasis because it could be post-tuberculous bronchiectasis as well. So these points will be mentioned in the history. In terms of clinical features, primarily what I will mention is that there is cough with sputum, but the word that I am going to use, copious amount of sputum. What do I mean by copious? More than 60 ml or very large amount of sputum. In other cases like pneumonia and all, you may not be having large amount of sputum, but these patients are bringing out large amount of sputum, copious amount of sputum. Okay. Second, in terms of signs, in the COPD, asthma, we get wheezing, rhonchi, and some specific signs like pursed lip breathing and all we saw in COPD. In patients with bronchiectasis, there is one important auscultatory finding that you need to remember. You are going to get crepitations or crackles, that too coarse crackles. Coarse crackles can also be called as crepitations. You are not getting these in patients with asthma or COPD, but once there is bronchiectasis, you will have these coarse crackles, crackling sounds heard during auscultation. You can easily recreate these sounds in your home or in your hostel itself. Take a glass, take a straw, put some water in the glass, put the straw and blow air into that water. Whatever bud 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 sound that you hear, that is your coarse crackles. Okay. So if the question is talking about coarse crackles, primarily think of bronchiectasis, and based on the context you can reach the diagnosis what could be the cause for bronchiectasis, whether his examiner is talking about cystic fibrosis or Carter-Jenner's or post-tubercular. And in terms of investigations, for a case of bronchiectasis, what examiner will mention? It's primarily radiological, because investigation of choice, the best way to recognize it is the high resolution CT scan. So HRCT chest is the investigation of choice, and what findings I am going to get. Please remember, mainly examiner will be talking about two radiological findings. One of them is called as track sign. The other one is called as signet ring or diamond ring sign. Either they may be talking about this, like question just mentions that it is track sign, or it mentions signet ring sign, or they may give you the CT image and where you have to recognize it. Okay, so what is this track sign? Chandan Patra, good. So what is this track sign? Now whenever you look at anything in nature which branches, just peep out from the window and see a tree. Like let us say if I am seeing a tree, how does it look like? Even if you ask a child to sketch a tree, this is how they sketch it. So even a child subconsciously knows that if it is a tree, if it is branching, it will always have tapering branches. What do I mean by that? When you look at the branch and you look at its proximal diameter versus its distal diameter, it is always tapering. The diameter goes on reducing, right? Proximal, distal, proximal, distal. It always goes on tapering. They don't run parallel to each other. No branch will be running parallel, perfect, right? They always go on tapering. And this applies to anything that branches in nature. Anything that branches in nature goes on tapering. So even our bronchial tree, it is branching, right? It starts with the trachea, then the main bronchi, the right and left bronchi. So when you look at the trachea, so after the trachea, as the main bronchi get formed, they taper. They taper. Their proximal diameter is more than the distal. Every branch goes on tapering. So when they become irreversibly dilated, especially the cylindrical bronchiectasis, when they become dilated, at least some of them, they may come to lie parallel to each other. Normally they should not look parallel, like their two walls should be tapering down, so they should be approximating, should not be running parallel. But if I pull them and make them dilated, so once it is dilated, it may become parallel. So when it becomes parallel, it is like the railway road track. That's why it is called as tram track sign. So if you find a HRCT where a bronchial tree perfectly appears to have parallel lines running, then we will call it as tram track sign. Naturally speaking, it should go on tapering. The same bronchial tree, if the HRCT cuts like this round appearance may give rise to a appearance of a diamond ring, then we will call it as signet ring sign. So if the question mentions the tram track sign or signet ring sign, or if the bronchi appears to be like one dot and the bronchial wall, or the two walls appear to be running parallel to each other, then it is sign of bronchiectasis. With the context that patient had copious sputum production, coarse crackles and these signs, you know that the question is talking about bronchiectasis. So this is how we recognize COPD, asthma and bronchiectasis from the question. Spam 42, absolutely right. So the bronchial wall and the small artery forming the diamond. So you can definitely gift it to your girlfriend. Okay, so now we know how to recognize asthma in a question, how to recognize COPD and how to recognize bronchiectasis. These were my major obstructive disorders. Now let us learn how to recognize ILD, ARDS and pneumonia from the question. So I will start with ILD. How will I recognize ILD in a question? So if the examiner is talking about, let us say, interstitial lung diseases, what will he mention? So there are several subtypes in the ILD. We will concentrate on the two major subtypes. The first one is called as idiopathic pulmonary fibrosis, and the second one is called as idiopathic non-specific interstitial pneumonia. Idiopathic non-specific interstitial pneumonia. So if the examiner wants you to think of the idiopathic pulmonary fibrosis, what all points he will mention? He will mention that the patient is elderly. In the history, he will mention that the patient is elderly. If the idiopathic NSIP is what he wants to think of, he will mention that the patient is young. When I say young, patient's age usually mentioned will be less than 40 years. And when I say elderly, the age usually mentioned is more than 55 years. Okay. Second, in the history, they may mention the gender. If examiner wants you to think of idiopathic pulmonary fibrosis, he will mention male gender. And if he wants to think of NSIP, he will mention female gender. Just like how for the bronchiectasis, the history of cystic fibrosis, cartilaginous or tuberculosis was important. For COPD, the history of smoking was important. Similarly, when it comes to the idiopathic pulmonary fibrosis, history of smoking is important. Majority of the patients developing IPF are smokers. But if it is idiopathic NSIP, these are usually non-smokers. These are usually non-smokers. Okay. Now that's about history. So in terms of clinical features, what they will mention? These patients, as usual, they will present with cough and shortness of breath. That's the standard for any respiratory disorder. Same here as well, cough or shortness of breath. But in terms of signs, I may get some clues. What signs I will get as clue? I will get fine crackles. Fine crackles. Here as well we will get fine crackles. So I hope we are getting the clues. Asthma, COPD, wheezing. Bronchiectasis, crackles, but coarse crackles. And in case of the ILDs, we are getting fine crackles. So I told you how to recreate those coarse crackles, right? A glass, water, straw, blow air, bud 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 that you hear is how exactly the coarse crackles sound. Okay. Now how fine crackles sound? If you have a like lady's purse or a pouch which has velcro, just open the velcro. While opening the velcro, you will hear that crackling noise. That's exactly how the fine crackles sound, and that's why examiners have a tendency to mention these as velcro crackles. Whenever examiner is talking about velcro crackles, is primarily pointing towards idiopathic pulmonary fibrosis. Examiner is directly giving you the diagnosis, like, okay, I am talking about velcro crackles, so please you people think of idiopathic pulmonary fibrosis. Okay. And in terms of investigation, of course I have to talk about PFT and I have to talk about investigation in interstitial lung diseases. Interstitial lung disease is a restrictive disorder. So if I do PFT, I will get the classical restrictive picture. And when I say restrictive picture, what does that mean? Restrictive picture means FEV1 by FVC will be more than 0.7. And this is where many students get confused. How will I get to know whether the patient is normal? Like he's normal, he's not having a respiratory disorder, or whether he is having a respiratory disorder which is restrictive, because in both the cases the ratio will be more than 0.7. Whether it is normal or restrictive disorder, the ratio will be more than 0.7 as we learnt here, right? It could be normalcy or restrictive. So how will I differentiate? Obstructive is very clear, ratio less than 0.7 obstructive hai, there is nothing else. But if ratio is normal, it could be normal or it could be restrictive. So how will I differentiate? So if it is pathological, means in that case your FEV1 and FVC will also be reduced. But if you have an individual where FEV1, FVC and the ratio, everything is normal, this ratio is more than 0.7 and these are normal, all the parameters are normal, that means you're dealing with a normal PFT. But if only ratio appears like normal, that is 0.7 plus, but other values are decreased, then it is restrictive. Clear? So once I have interpreted the PFT as restrictive, I should be thinking of ILDs, pneumonia and other restrictive causes like pneumothorax, pleural effusion. Okay. So now, how will I confirm that it is not pneumonia but rather ILD? Of course, history is very, very important. ILDs are chronic disorders. Your pneumonia is of course an acute disorder. You can't say that there is I have met a patient who was living with pneumonia from last 2 years. No, if you have pneumonia, after 4 to 6 weeks, either pneumonia is there or you are there. It can't be like live with pneumonia for 6 months, 1 year, 2 years. Pneumonia is an acute condition. But ILD is a chronic condition. I can show you patients of IPF living from last 5 years, 6 years on medications, of course. Okay. So HRCT will definitely help you to differentiate between the two subtypes of ILD as well as pneumonia. So if it is HRCT is showing off what we call as usual interstitial pneumonia pattern. What does that mean? When you get this word UIP pattern, that means radiologist is seeing extensive bronchiectasis called as traction bronchiectasis and too many bronchi dilated, giving rise to whole lung appearing like a honeycomb. Traction bronchiectasis plus honeycomb changes honeycomb changes, then it is suggestive of idiopathic pulmonary fibrosis. And if the radiologist reports it as NSIP pattern itself, NSIP pattern, when do they report it as NSIP pattern? When they see what is called as ground glass opacities. If they see extensive ground glass opacities, then the radiologist report it as NSIP pattern, and as the name suggests, for me that is equal to NSIP. So now how do I recognize ILDs? ILDs, PFT will show the restrictive pattern, and of course ILDs are all majorly chronic disorder except some hypersensitivity pneumonitis, acute hypersensitivity pneumonitis. They are majorly chronic disorders. So chronic disorder with cough, shortness of breath, examiner mentioning velcro crackles or fine crackles, and PFT giving the restrictive picture is going in favor of ILD. Same restrictive picture but acute condition, you can think of pneumonia as well. Okay. Then HRCT will clearly hold the diagnosis. HRCT can show you pneumonia. It can also show you these patterns. So if UIP pattern, think of IPF. NSIP pattern, think of NSIP. Okay. Again, to make it easier for you to remember the two subtypes of ILDs, all you have to remember is IPF. A classical case of IPF is an elderly male with a smoking history. And exactly opposite of it is a classical case of idiopathic NSIP. Elderly male smoker is at risk of developing IPF. Opposite of it, young non-smoking female is at risk of idiopathic NSIP. So those who are watching now should start thinking like, am I young? Am I female? Do I not smoke? Well, if you have these three things, you are at risk of developing idiopathic NSIP. And just to avoid the risk, don't start smoking. This, even if it happens, it is more easier to treat than the IPF. In an attempt to come out of this, you may start smoking and end up with COPD, carcinoma of the lung and other complications, right? Not advisable. Okay, so now we know how to recognize a question on ILD. Now the only thing that from the respiratory system I need to learn is how to recognize a question on pneumonia and ARDS as well. Okay, now how do I recognize a question on pneumonia? What context examiner will give me? Because pneumonia based questions are often like, they will give you a story. From the story you have to recognize that the examiner is talking about pneumonia, and then they will ask you whether I should admit this patient as inpatient or to ICU or treat it as the OPD. So what pointers I will get? So if the question is about pneumonia, examiner will mention that patient presents with pneumonia is also a restrictive disorder. That is your FEV1 decreased, FVC decreased, and FEV1 by FVC ratio, main thing is ratio more than 0.7. They will mention cough and shortness of breath of acute onset, short duration. They will not say that the patient is having cough and shortness of breath from 3 months, 6 months, 1 year, 3 days, 5 days, 6 days, 7 days. That's the usual story. Okay. Now, here in the history, there may be some additional clues as to what could be the cause for the pneumonia. So what clues I am going to get in the history? If the question mentions, let us say community acquired pneumonia, no hospital exposure or anything. If the question mentions that the patient is alcoholic. If the question mentions that the patient is drowsy, they are all pointers towards different organisms. If the question mentions that patient is HIV positive individual or a person living with the HIV. So another point is if it is hospital acquired pneumonia. So if the question is mentioning that patient is not alcoholic, not drowsy, not HIV positive, no hospital acquired pneumonia, of course you should think of the streptococcus pneumoniae, Streptococcus pneumoniae as the most likely cause for this patient's pneumonia. If they mention that patient is alcoholic, it could be pointing towards either Streptococcus pneumoniae or another important, it is Klebsiella. So any question on pneumonia which talks about patient being alcoholic, Streptococcus pneumoniae continues to be an important cause for pneumonia, because overall that is the most common cause. Most common cause for pneumonia is Streptococcus pneumoniae. So they will continue to be the cause in drowsy, HIV positive, hospital acquired in all cases. But if the examiner is setting the context that it is hospital acquired, I want you to strongly think of Klebsiella. Okay. Then what other clue I may get if the patient is having Klebsiella? If patient is having Klebsiella, they may mention a sputum which is called as red currant jelly sputum. Exactly looks like your mixed fruit jam. The sputum looking like mixed fruit jam, red currant jelly sputum. Another radiological finding that they may mention in the question if it is Klebsiella pneumonia is that the patient is having something called as bulging fissure sign. Bulging fissure sign. If it is Streptococcus pneumonia, they may mention rusty sputum. Okay. If the patient is drowsy, what should come to your mind? Aspiration pneumonia. When the patient is drowsy, they may not be able to protect their throat. Whatever secretions that collect in the throat may go into the lungs and cause aspiration pneumonia. And the most common cause for aspiration pneumonia are anaerobics. Anaerobes. So it is most likely going to be anaerobic infection. I think all of you know, if the question is mentioning HIV, what we should think of first, especially when the CD4 count is less than 200, we should think of Pneumocystis jirovecii. Pneumocystis jirovecii. Okay. And if it is hospital acquired, you have to consider thinking about Streptococcus pneumonia, but in addition to that, you should also think of Pseudomonas. And whenever you have Pseudomonas infection, they may mention blue or bluish green sputum. So if the question talks about someone hospitalized for a long time, now developing cough, shortness of breath and bluish green sputum, it is pointing towards Pseudomonas. Okay. Similarly, in the history, if they mention that the patient is a known case of cystic fibrosis, again, what is the most common cause for respiratory infections in patients with cystic fibrosis? It is again going to be Pseudomonas. So history is not only about acute onset cough, but there may be other pointers to think of specific organisms in a clinically oriented questions. Okay. Now here, another thing that I forgot to mention is that patients with pneumonia often have fever as well. You may not get fever in asthma, COPD or ILD patients or bronchiectasis, but in patients with pneumonia, you do get. That can be another pointer to think that it is a case of pneumonia. Now, when someone presents with cough, shortness of breath of acute duration, and I'm thinking of pneumonia, what investigations I am expected to do? So as usual, PFT generally we don't do, but we should be aware if PFT is done, it is going to show your FEV1 by FVC ratio of more than 0.7. FEV1 is usually reduced and FVC is usually reduced. But if you ask me what is the investigation of choice that I should do, it is going to be imaging. Imaging can be either in the form of X-ray or HRCT. And what examiners will mention, how do I recognize that it is a case of pneumonia that the examiner is talking about in the imaging? Mainly imaging will show affected part of the lung showing consolidation or solidification of the Lung. Normally lung is aerated, right? It's like sponge full of air in the acini. But once there is infection of this acini, the acini get loaded with pus. It becomes solidified. That's what we call as consolidation. In pathology, the sir will teach you as hepatization, right? Lung becoming solid like liver, so we call it as hepatization. So you have initial red hepatization where inflammation is there, some RBC leak into the acini is there, and then when healing starts, it is gray hepatization. So this consolidation, how will I recognize on the imaging? What is the best sign to recognize that there is consolidation present? Surest sign, because lung is full of air, so it will appear black. When it becomes solidified, it will appear white. It will be an opacity. But if I have pleural effusion, that will also have opacity. Like if I look at the X-ray, right, it may be showing the lung fields. And if I have pleural effusion, then also it will look white. If I have consolidation some part of the lung, then also it will look white. If there is a tumor, that will also look white. So all these white opacities, how do I differentiate? So please remember, when there is consolidation, you will still have bronchi running within this solidified lung, where bronchi may be having the air and that air may still appear black. So what we call this sign as, where there is still air visible in the bronchi, which is like in the background of white opacity, you have bronchi visible. We will call it as air bronchogram. Air bronchogram. It is called as air bronchogram. So if you find one air bronchogram on the X-ray, you know it is consolidation. In the context of fever, cough, shortness of breath, you are going to take it as pneumonia. Okay. So few points sir will discuss again in radiology as well. So if I get an opacity, like let us say that this is the X-ray that we are looking at, and if there is a white opacity which has a meniscus, in the sense there is an opacity whose upper edge is not one straight line, but it is concave, then we will call it as meniscus sign. This is called as meniscus sign. Concavity is there and the concavity tip is ascending towards the axilla. We call it as meniscus sign. It is called as meniscus sign, which is typical of pleural effusion. This is how pleural effusion looks like. You already know earliest is opacification or blunting of CP angle, and as more fluid accumulates, you will have an upper edge to fluid which is concave, with the concavity tip ascending into the axilla. You call it as meniscus sign. So if I get another X-ray where there is an opacity, and that opacity has bronchi visible through it. Like let us say I am getting some opacity here. And in that opacity, I can still see one of the bronchus running. Then it is suggestive of pneumonia. Mainly it is suggestive of consolidation. Consolidation in the right context is equal to pneumonia. And this visible bronchus, we call it as air bronchogram. We call it as air bronchogram. Okay, so another thing I forgot to mention in the clinical features itself. In terms of clinical features, okay, let me add another slide. What else the examiner may give you in terms of clinical features, or let us say signs in a patient of pneumonia? What signs the examiner will mention? So first thing examiner will mention is that on auscultation, in asthma COPD we are getting wheeze rhonchi, in the ILD we are getting the fine velcro crackles, in case of bronchiectasis we are getting coarse crackles. In case of pneumonia, what do we get? In case of pneumonia also we generally get coarse crackles on auscultation. Sir, in that case I will get confused with bronchiectasis. No, On auscultation, you get one more thing, that is bronchial breath sounds. You get bronchial breath sounds. Normal breath sounds is normal vesicular breath sounds. Here you get bronchial breath sounds. Bronchial breath sounds. Now what is this bronchial breath sounds? The sounds is actually produced in the trachea and bronchi, not in the acini. So as we see that there are a lot of acini, the sound actually gets produced in the trachea and bronchi. This is where the sound gets produced. This sound, as it passes through these acini to our stethoscope, which I am placing on the surface and I am listening, the sound is produced here, and then this sound travels through these acini. Acini are nothing but air pockets, right? Air pockets, spongy tissue, like sponge. Sponge filters the sound. So now, okay, you may not be able to see, but generally when you see mics have a sponge on it because they want to filter some harsh frequencies. So same thing here, right? So some harsh frequencies are produced in the trachea bronchi. That is the actual sound. But that sound, when it travels through the spongy tissue, some harsh frequencies get filtered out, and what you hear is only softer frequencies. Softer frequencies. So normal sound itself is the sound which can be called as tracheal or bronchial sound. This sound, as it gets filtered through the aerated lung tissue, we get what we call as normal vesicular breath sounds. So bronchial breath sound got converted to vesicular breath sound. But when we have pneumonia, what happens? All these acini are now filled with pus. They have become consolidated or solidified. So they are no longer acting as the mic filters. So the sound which is produced in the bronchi, that harsh frequency, now gets directly transferred to your stethoscope without any change. So that's why we are going to call it as bronchial breath sounds. Within that bronchial breath sounds, yes, you have subtypes like the tubular, cavernous, amphoric. So the kind of bronchial breath sounds you are going to get here is tubular breath sound. Tubular breath sounds. So examiner may mention that as well. Okay. And if it is pneumonia, if I percuss here, what kind of note I am going to get on the pneumonia? Normally lung is air and air gives us resonant note. Once I replace that air with solid tissue, the resonance is lost. So in percussion, what kind of note I am going to get? I am going to get a woody dull note. The examiner may mention a woody dull note. Okay. What else he may mention in the examination? If you ask this person, right, if you ask this person to speak some words, when he speaks some words, those words generally do not come to the stethoscope unfiltered because this tissue filters it. But now that the lung is solidified, as he speaks, whatever he speaks comes to the stethoscope unfiltered, as if he is directly speaking into your ears, because I've replaced the aerated tissue with the solid tissue. Normally aerated tissue acts as a filter. Now it is not there. So this phenomenon, we call it as whispering pectoriloquy. We call it as whispering pectoriloquy. It feels like the patient is whispering directly into your ear, not he's speaking and you're not picking it from the stethoscope. It feels as if he's directly talking into your ear. So these clues may be there in a case of pneumonia. Ultimately, diagnosis happens with the help of X-ray. And main thing you have to remember, I want you to remember, is the consolidation and air bronchogram. Once you know that, okay, it is a case of pneumonia, then examiner may be asking further, like, what is the most likely organism? So based on the context, if he's talking about alcoholism, think of Klebsiella, or if he's already given the clue that there is red current jelly sputum, think of Klebsiella. If he's talking about hospital acquired pneumonia, think about Pseudomonas. If he's talking about community acquired, think about Streptococcus pneumonia. From there, he may also ask you regarding the decision to hospitalize inpatient versus outpatient, regular inpatient versus ICU. For that, you know that there is something called as curve 65. Yes, you will get egophony as well. You will get egophony as well. So Tapasamanta, basically what happens is, a good conductor of sound is this solid. air is not a good conductor of sound, right? And acini being spongy, they filter some frequencies. So if you ask someone to speak something, the same sound will not be heard on the stethoscope because the voice produced here. If you directly hear, yes, but whatever the voice they produce, as it passes through the trachea, bronchi and enters into the parenchyma or the acini, and then from the chest wall it comes to a stethoscope, lot of filtration happens. So it doesn't sound like normal speech when you hear it through the stethoscope. But now that I have solidified these alveoli, they are all pus filled, they have become consolidation. So aerated tissue is replaced now by solid tissue, and solid is a good conductor of sound. So the voice reaches your stethoscope unaltered, as if he is directly talking. Now you can do this experiment, like ask one of your friend to whisper something, keep the stethoscope on the chest, and it doesn't sound like he is speaking to you normally. But you do that in a patient with pneumonia, you will be able to hear it very clearly. We will call it as whispering pectoriloquy. Okay, so now we know how to recognize a question on pneumonia as well. Now another important respiratory disorder that we have to recognize from the question is ARDS. ARDS. Many of you know that ARDS is also called as non-cardiogenic pulmonary edema. So here patients develop pulmonary edema, that is collection of fluid in the alveoli, without a reason, without a cardiovascular cause. So how will I recognize that the question is talking about ARDS? First thing, though it is of course a restrictive disorder, but generally PFT will not be mentioned. It is mainly the history that helps you to recognize that the question is talking about ARDS. What will be the history? History will mention some insult in the body. When I say insult, that means it could be trauma, it could be infection, okay, sepsis, or mismatched blood transfusion, anything that can trigger inflammation in the body. This inflammation results in formation of inflammatory cytokines, and those inflammatory cytokines, like basically what is ARDS is that you have some trauma. Like the very last ARDS patient I saw, he developed ARDS after snake bite. So he had a snake bite. So snake bite triggered inflammation in his limb where there was a bite. And once there is inflammation, there will be formation of inflammatory cytokines like interleukin 1, interleukin 6. These inflammatory cytokines won't only stay in the site of inflammation, like trauma somewhere, like there is a crush injury, inflammation. Those inflammatory cytokines will travel through blood from that site of inflammation and they go to lungs. And in the lungs also they will cause inflammation. So when they cause inflammation in the lungs, usually it takes less than 7 days for the lungs to get affected. The patient will present with sudden onset shortness of breath. Sudden onset shortness of breath. This is how the context is set. Like a patient presented with urinary tract infection, diagnosed as sepsis, and then on day 4 of the hospital, he started developing sudden onset shortness of breath. That's the build-up for the ARDS. So what does that mean? He had a urinary tract infection. So there was inflammation of the urinary tract. Inflammatory cytokines formed because of that infection have reached the lungs and caused the damage to lungs, and that's why he's developing sudden onset shortness of breath. And from the insult to the onset of symptoms, it should be less than 7 days. It can't be a question where it says that 1 year back he had a urinary tract infection, now he's having sudden onset shortness of breath. Don't think of it as ARDS. Should be bridged by less than 7 days gap between some inflammatory event happening and then patient developing shortness of breath. Okay, then what clinical features they will mention? They will mention, of course, shortness of breath. Most importantly, they will mention hypoxia. Saturation will be low because alveoli are filled with fluid, right? They will not be able to participate in the gas exchange. So they will mention hypoxia, and they will also mention PaO2 by FiO2 ratio. What is this PaO2 by FiO2 ratio? Patient's oxygen level in the blood as partial pressure of oxygen in the blood and the fraction of inhaled oxygen, means how much oxygen is taking and how much is his blood oxygen. We are taking a ratio of it. They will mention that this ratio is less than 300, less than 300. Okay. And if the question is about ARDS, as we have already discussed, ARDS simply refers to non-cardiogenic pulmonary edema. That means there is a case of cardiogenic pulmonary edema where there will be heart problem. Here a patient is developing pulmonary edema without heart problem, and this is because of some inflammatory event triggering all the inflammatory cascade. So if I have to build a question, how will I build? I will mention in the investigations that the chest X-ray or HRCT is done, which is suggestive of pulmonary edema, which is suggestive of pulmonary edema. And when there is pulmonary edema, you know this classical bilateral alveolar opacities, bat wing appearance, all of that would be there. Okay. Then to make sure that you are dealing with a non-cardiogenic pulmonary edema, in the question examiner will mention that the two-dimensional echocardiography is normal. It is not showing any abnormalities. If it is showing, let us say, mitral stenosis or left heart failure features, low ejection fraction, then it is talking about heart failure. It is pointing towards cardiogenic pulmonary edema. The echo he will mention as normal, and as we just discussed, they may mention an ABG showing hypoxia where you will have PaO2 by FiO2 of less than 300. Normal is more than 400. Okay. And then what else they will mention in the investigations? They may mention other investigations suggestive of inciting event. Like for example, there may be an investigation which is showing that urine is full of pus, or there is formation of a abscess, perinephric fat stranding or abscess in the kidney pointing towards pyelonephritis, which is directly indirectly telling you that okay, I am also giving you a clue that there was an event, some infection or some inflammatory event, and that has led to all these consequences, right? So that's how the investigations will be mentioned. And from there you can come to the conclusion that you're dealing with a case of the ARDS. And just because I'm talking about ARDS, before I go forward, let me tell you that for the diagnosis of ARDS, we follow a criteria which is called as Berlin criteria. You should be aware about it, which is the same points that we just discussed. What are those? Berlin criteria says you can call a case as ARDS, acute respiratory distress syndrome, if the patient is having number one, hypoxia, which is defined as PaO2 by FiO2 ratio of less than 300, less than 300. Second, imaging, that is chest X-ray or HRCT showing bilateral pulmonary edema. Third, normal two-dimensional echo, or if you have done any higher cardiovascular investigation is also fine. And the fourth one, onset of symptoms should happen within 1 week of symptoms, within 7 days of an inciting event or insult. Then it is a case of ARDS. Clear? So this is how we approach the diagnosis of respiratory medicine clinically oriented questions. So I'll just give you a quick summary before we sign out for the day. So whenever we are dealing with a respiratory medicine clinically oriented questions, most of the questions will have cough and shortness of breath as a standard symptom. There may be some additional symptoms which will help you to diagnose. For example, if it is asthma or COPD, wheezing may be mentioned. If it is ILD or let us say bronchiectasis, cough with expectoration may be mentioned, especially bronchiectasis or pneumonia. In the ILD, the other context like the patient being smoker or non-smoker, that may be mentioned. In the ARDS, they may mention a history of some inciting event, some ongoing infection or trauma or mismatched blood transfusion or a snake bite or something like that. Okay. Then, anytime I read such questions, I have to know to differentiate between obstructive and restrictive. For that, we are taking the help of PFT, primarily looking at the ratio. Ratio less than 7, it is obstruction, and if it is more than 7, it is restriction. If it is obstruction, we are thinking of conditions like asthma, COPD, bronchiectasis. If it is restrictive, we are thinking of conditions like ILD, ARDS, pneumonia, pleural effusion, those conditions. In case of obstructive disorder, where we have to differentiate between asthma and COPD, asthma is reversible, COPD is non-reversible, we go for what we call as bronchodilator reversibility test. If I see more than 12% or equal to 12% jump in the baseline FEV1 after the bronchodilator, it is asthma, reversible obstruction. If I don't see that much jump, it could be COPD or bronchiectasis. In the COPD, examiner may mention history of smoking, he may mention pursed lip breathing, barrel-shaped chest, tripod position, right? In case of bronchiectasis, he will mention copious expectoration. He may give the context or history of tuberculosis or other conditions known to cause bronchiectasis like the Cartagena syndrome, cystic fibrosis, right? Young syndrome, those will be mentioned. Okay. Then for the ILD, there are two subtypes, IPF and NSIP, that you need to remember. Context is very, very important. If it is IPF, examiners will mention that it is elderly male smoker, and if it is NSIP, he will mention that it is a young non-smoker female. In both the cases, here we had wheeze, here we will have fine crepitations, also called as velcro crackles. Okay. If it is bronchiectasis, the examiner will mention again the copious amount of sputum, and in case of bronchiectasis, he will mention the coarse crackles. ILD, we had fine crackles. ILD is restrictive, bronchiectasis is obstructive. Okay. In case of pneumonia, they will mention the acute onset cough and shortness of breath. They may give you an X-ray with a consolidation with air bronchogram visible, and in the history they may give you some additional context for you to think of organisms, community acquired versus hospital acquired versus alcoholic, HIV positive individuals, all that. And in the ARDS, the context will primarily focus on an inciting event or an inflammatory event. Within 7 days, patient developing pulmonary edema on the X-ray, shortness of breath and hypoxia with PaO2 by FiO2 ratio less than 300, and because it is non-cardiogenic pulmonary edema, examiner will mention that echocardiography appears normal, there is no regional wall motion abnormality, and the ejection fraction is normal. So with that, we should be able to recognize what the disease the examiner is talking about. After that, it becomes a one-liner. Once you know that, okay, this is a question of asthma, then everything else that is there is one-liner. They may be asking what is the investigation of choice, what is the initial treatment of choice, what is the treatment of choice when patient is not responding to standard treatment, what is the most common cause of death, then it is one-liner. So this clinical masterclass, we are trying to convert all these clinically oriented questions by looking at the clues so that they become one-liner for us, right? So notes will be shared on the Telegram. So for today, that's it. I've already covered neuro and cardio, how to recognize different neuro and cardio diseases, which is available on the MedEd Next, our sister channel. Please go through that as well. And if you want me to do any other system, this clinical masterclasses, let me know. I will cover it in one more session. And the session is going to continue. I mean, in the sense, tomorrow, day after tomorrow, other subject teachers will also give you clues how to make the diagnosis from the clinically oriented questions. So from me, that's it today. The notes, I will share it with the team. They will load it on the Telegram. See you soon, guys. Study well and rock. See you. Bye-bye. Isha Vipin, okay. I will try to have a session on like whatever we have discussed so far, same thing through questions. One session, we will get a better idea how to deal with questions as well. Okay. Thank you, guys. Bye-bye.